Welcome back, everybody. David here again with Med School Boot Camp. So in this next chapter, we're going to talk about a variety of different musculoskeletal pathologies that are specifically related to our pediatric patients. So this chapter is our childhood musculoskeletal pathology. And we're going to talk about a lot of different things here that can show up on test day. These include things like radial head subluxation, pediatric fractures, developmental dysplasia of the hip, slipped capital femoral epiphysis, sometimes also called SCFE, LCP, patellofemoral syndrome, Osgood-Schlatter disease. So there's a lot to unpack here, but we need to be able to differentiate these conditions because they can have a lot of overlap and a lot of similar findings, and that's what we're going to discuss in this chapter. So in this first video, we are going to talk about something called radial head subluxation. Sometimes this is also called nursemaid's elbow or even pulled elbow, and after we finish this video, you'll kind of understand why it's called those things. So first, let's take a big picture view and orient ourselves, right? If we think about our anatomy and we look over at this normal elbow joint, we have a couple key structures, right? We have the humerus, which makes up the upper arm, and then two in our forearm known as the radius and the ulna. Now, a very important key structure that is vital in understanding this pathology is something called the annular ligament. And the annular ligament is a stabilizer of the proximal radial-ulnar joint. And so kind of being familiar with this general overview, this normal bone anatomy is going to be important when we talk about the pathophysiology of what actually occurs in this condition. So if we think about the etiology here, the most common cause of this condition is going to be trauma, specifically an adult pulling a child's extended arm. This is classically going to be seen in young children less than 5 years of age due to the immature cartilage and ligamentous structures, right? It's unlikely that this would be seen in an adult, one, because it's kind of hard to pull them up, as you can kind of see in this image right here, but two, because the ligamentous structures around the bone, around the joint, are more solidified as we age. They're not as flexible. They're not as likely to be dislocated from one another. So what exactly is going on here? Well, again, it's important we understand our anatomy. So if we consider this image here, which again highlights all the main structures we talked about, the humerus, the radius, and the ulna, we can see this important structure, the annular ligament. See how it's kind of round and it kind of goes around that radial-ulnar joint. Well, what happens is, as a child gets pulled up abruptly, you can see this upwards traction to the joint can actually pull this bone out, right? So you see the child being pulled up forcefully here, and you imagine that this is the proximal portion of the arm, the humerus. This is the distal portion of the arm. So essentially, if we look at this image and we kind of show it here in the anatomy, this is a force going this way. The radius isn't going to be pulled out from the annular ligament. Now, once the radius is actually pulled out because of the traction to the arm, again, going this way in the image, what's going to happen? Well, the annular ligament, which we see right here, can kind of slip under that bone and actually become entrapped between the humerus portion right here and the radius portion right here. We kind of had the ligament there in the middle. It's stuck. And this is a very classic presentation. And the pathophysiology is entirely based on the mechanism of injury. So here's the mechanism. A traction force occurs, the radius is pulled out, the annular ligament then slips under or on top of the radial bone, and this can be a source of pain for the patients. Additionally, patients are at increased risk if they have congenital conditions such as abnormal collagen development. And again, this makes sense when we think about our pathophysiology, and that a ligamentous structure is actually getting trapped in between bones or in between a joint here. And so patients who have a collagen defect are more likely to have this occur. The pathophysiology is that a forceful or sudden traction on a pronated/extended arm leads to annular ligament slipping over the radial head. And we showed that in the previous image. So the key point to focus in here is why pronated and extended. Well, the extended part makes sense, right? Because think about it. If this is an extended version of the arm, right, and a traction force is applied, it's very easy for this to pop out, the ligament to drop under. However, if the arm was kind of bent more this way, it's really hard to apply that traction force to get the annular ligament to dislocate. Similarly, children are at high risk if it's a pronated arm. Recall, in a pronated arm, the palm is facing down versus a supinated arm, the palm is facing up. And you think of the supinated arm as in you're trying to hold a cup of soup. If you were to pronate and turn the hand down, you would drop your soup. And so that's how I remember supinated, palm is facing up. Pronated, palm is facing down. So again, patients are not always in this position, but this is a very classic or high-risk position for children to be in. Now, when we think about the presentation here, super classic finding. Patients present to the ED, they're going to have a flexed elbow, a pronated hand, and hold it near their body. Patients will also have pain and tenderness around the elbow. And again, this makes sense. A traumatic injury has occurred. A bone has been pulled, potentially subluxed, and now a ligament is trapped in between two bones. Patients will also have a normal neurovascular exam. This is very important because there are a lot of other things that these patients can have. Elbow injuries in pediatric patients can be a variety of different things. One of the can't miss things is a supracondylar humerus fracture, and we have a whole video about that coming up in this chapter, but that is essentially a fracture above the condyles, a supracondylar, so it's above the condyles of the humerus that can occur and present with elbow pain. It's really important because this can actually damage neurovascular structures, and you have to be sure to rule this out when you're assessing these patients. But here we're saying that a normal neurovascular exam will be present. So these patients do have a painful joint, but typically the nerves, the arteries, the veins should not be affected in this condition. Other things you need to think about with elbow pain include radial head fractures, potentially elbow dislocations, or potentially just a soft tissue injury, because kids tend to fall for a variety of reasons. Now, anytime somebody has an elbow injury and there's tenderness to palpation, they're likely to have decreased range of motion, right? Why? Because it hurts. It hurts to move the joint. Potentially it's just due to pain, or there's restriction, right? If there's a fracture that has occurred, that can actually restrict the joint itself. In this case, we have a structure that's literally displaced, and in the way it might not allow patients to go through the full range of motion, and so this would be an understandable finding. Now, key point here, these patients lack significant swelling, and this is one of your primary differentiating things between a lot of the other traumatic injuries, such as the fractures or even the elbow dislocation. Typically, this is due to a fairly quick incident that pulls the ligament between the bones, and so not a lot of swelling is going to occur in that area by the time they presented to be evaluated. Now, when we think about the diagnostics here, this is typically going to be a clinical diagnosis. That is to say, we don't necessarily need imaging. It's based on the history, the examination, and the presentation of the patient. So you don't always need imaging. However, if you fail to reduce the arm, which we'll talk about in the second in the management section, you may consider some imaging to rule out a fracture. For management here, these patients are going to need closed manual reduction. So what does that mean? Well, what's going on here? Think about the pathophysiology. We have a displaced ligament between the bones within the joint itself. Well, we need to get that ligament back into place. We need to manually reduce it. We need to get this bone outwards so this ligament can go back to its normal home and return to be a normal appearing joint. And there's two primary ways they do this. Not something you necessarily need to know at this level, but I want you to be familiar with it in case it does show up. That is the hyperpronation maneuver. Again, patients typically present with a pronated presentation, right? And so now you're basically taking that and you're hyperpronating it. You're turning it even more in that direction. And that is essentially going to allow the ligament to be free and return to its normal anatomic position. Additionally, another maneuver is called the supination flexion maneuver. And this has to do with doing the opposite. You're now supinating the hand. So you're turning the hand up and you are flexing it. So you're bringing it towards their body. Remember, extension of the arm, flexion of the arm, pronation, supination. So let's quickly summarize what we learned in this video, and then we'll do a practice question to wrap this up. This is going to be radial head subluxation, sometimes also called nursemaid's elbow. When we think about the etiology here, most common cause I need you to know is that trauma is likely to occur. An adult quickly pulling a child's arm, we talked about the mechanism here, right? Pulling on the arm leads to traction on the radius, allowing the annular ligament to kind of slip in between, which you can see on this elbow subluxation image right here. Pathophysiology, again, forceful traction, typically in a pronated extended arm, but not always, leads to the annular ligament slippage. Presentation, elbow flexed, pronated, held near body. Very classic presentation in a pediatric question and even in the real world itself. Additionally, these patients can present with pain and tenderness around the elbow, decreased range of motion, lack of significant swelling, and they will have a normal neurovascular exam, right? If neurovascular structures are damaged, you're going to need further workup. You're going to need further imaging, potentially even surgical intervention, as likely it's one of these things that has occurred rather than the nursemaid's elbow. When we think about the diagnostics here, often clinical diagnosis often don't need imaging. We talked about what are the exceptions. Well, neurovascular compromise would definitely be one of them. Management here is going to be reducing. A closed manual reduction of the arm can actually allow the ligamentous structure to return to its normal anatomic position. So how might they ask you this in a question stem? Well, they might ask you something along the lines of, a 4-year-old child presents to the pediatric emergency department for evaluation of left elbow and knee pain. The father reports the patient tripped and fell forward while they were out for a walk, landing on the left hand and knee. The father reports he helped the son up from the ground by pulling him from his left arm. On physical exam, you notice a small, non-bloody scrape on the left knee, as well as good skin perfusion and distal pulses. The child is holding the left arm near the body with 90 degrees of flexion. The arm is neurovascularly intact, and no appreciable swelling is noted. The question could then ask, which of the following does the patient most likely need at this time? So there's a bit to unpack here, but if we think about the key important things, there was an injury, right? The patient fell on his knee and hand. He was then pulled up by his father by his left arm. The patient exam is notable for him holding the arm near his body at 90 degrees and being neurovascularly intact. So there's a lot of things we need to consider here. We need to consider our differential diagnosis. The patient had a fall at first. Could they have fractured something? Potentially. However, based on the physical exam findings of being neurovascularly intact and the patient's presentation of holding the arm near the body at 90 degrees, this is a very classic presentation for radial head subluxation. And so one of the possible answer choices could be to do manual reduction and improve this patient's symptoms. Now, you could make the argument that an x-ray needs to be done first because of the traumatic injury, and that would be reasonable. However, there's really nothing in this question set that indicates on examination that the patient actually has a fracture. So in this case, the best answer would be to do manual reduction, as this patient likely has a radial head subluxation from his father pulling him up after the fall had occurred.